You probably agree with me that Karen is our favorite force of nature. And our journey really started with an introduction by Stan Wallach that really raised a very important question for us. Is since we were so invested in developing systems-based practice, why were we maybe not uniformly, but commonly unsuccessful in making it a effective part of the curriculum? And that's from the residents' feedback. So Karen actually posed this challenge to us, and she's great at really catalyzing people to come together. And I'm going to talk about the journey we went through to really develop a position paper on systems thinking, and then we went out and got more funding and actually are going to start doing a proof of concept about the importance of systems thinking as a foundational element in medical education, which I think we don't necessarily appreciate how critical it is for not only our faculty, but our students to really be able to solve problems within their institution. And Chuck Kylo would agree with me that this really helps us make better decisions. So just to talk about the Pcast report, it's a great report if you haven't read it. It's the President's Council of Advisors on Science and Technology, and this year they basically focus on systems engineering. And actually they advocate for broad payment reform. They talk a lot about systems engineering tools. Again, tools that some of our schools, but not all of our schools, teach and or use within their own institutions. But we were reminded constantly by the group of experts that we pulled together for an advisory group and met last summer here in the offices of the Jewish Healthcare Foundation, that the tools are necessary, but they're not sufficient to drive permanent, sustainable change. And we lost the thread years ago about systems thinking. Systems thinking is where systems practice and a lot of our application of organizational improvement tools came from. But it started with systems thinking. And for healthcare, this is a little bit foreign, and I'll explain why. First of all, this came out of MIT professors' efforts in systems dynamic, and it considers evidence, human behavior, social systems, and organizational systems in defining solutions. Now, any of you here that are involved in public health or community health, you say, yeah, we do that all the time. But unfortunately, in healthcare, we don't always do that. And I think that relates simply to we have actually quite a reductionist approach to solving our problems. I'm not saying that how we solve problems in healthcare is bad. I mean, some of the best science in the world has come from our ability to remove variables and compare two cohorts of a population and decide, what drugs work on what diseases. And that is the way we advance medical science. But we can't actually solve a lot of our systems problems that way because the world is complex. We cannot remove those variables and identify a solution and then plop it back into the real world. We need to teach our students an appreciation of systems thinking, that they have to really look at all the complex variables as they design a problem. I mean, I'll ask everybody in the room, how often have you designed a solution to a problem and you said, this should work, this is a great solution, and you put it into place and it failed miserably? And it failed miserably usually because you didn't appreciate all the human behavior, the social, the organizational structures that had to be considered if you're going to really identify the best solution. Chuck is really big, Chuck Kylo and Michael Bly from the Goldfarb School of Nursing in St. Louis, and Jim Bajan, who's the head of safety science at University of Michigan, are three people that have been really helpful thinking through this process. And Chuck is really big on definitions. So he says the system is defined as independent parts with a common purpose. Makes sense. Systematic thinking is very logical. Sometimes it's very linear. Systems thinking is a little bit different. It involves complexity theory. And basically, complexity theory really it explains how you move from total chaos to actually having a space where you create innovative solutions. And if you actually have too many controls on your systems, you actually become kind of command and control and burdened with processes. So complexity theory really addresses the fact that there's a continuum between chaos and overburden with controls. But complexity theory also explains how we are trying to create order from our complex adaptive systems. And all of you have heard healthcare in general, healthcare systems in general, are complex adaptive systems, and they're learning systems. If you do something to the system, it's smart enough that it's going to figure out how to continue to do what it's incentivized to do, because it learns how to work around or avoid an obstacle that you've put in the way, which is why policy sometimes has unintended consequences. It's why some of our interventions in communities don't work, because we actually don't understand what are the other incentives and drivers within the system. So how good are we at this in healthcare? Really, we're not very good at all. And we like to actually train our leaders. And a lot of our CEOs actually get this. You know, a lot of them come from business schools, a lot from engineering backgrounds, and they understand the importance of this. We have to actually teach our faculty that the methodological reductionism that is the basis for a lot of our medical science is important, but it is not the way we want them to analyze health system problems. They have to back up and look much more broadly. So I'm going to do a little exercise. So let's talk about building a bridge. So what do you need to consider when you're building a bridge? Just take 10 seconds and think about what would you like to know if you were going to build a bridge. How long does it have to be? What else? Where is it?
How deep the water?
How deep the water?
The stresses that will come under it.
The stress?
Does anybody want it?
Does anybody want it?
Who's gonna pay for it?
What else?
How high is
Where
it?
do you want to get to?
Hi?
What's going over it?
What's going over it?
Entrance ramp.
Where is it going to get you to?
Who's gonna pay for it?
Who's going to pay for it? Anything else? I mean, you could even get broader. You could say, how's it going to affect the communities that are at the beginning and end of the bridge? What's it going to do to the ecosystem? What's it going to do to the current of the river? What's it going to do to the boat traffic? When you start to really think about this, you realize the building a bridge is much more than the structure and the materials. It has to do with many other components of the system that it's going into in order to have a successful bridge. And if you ignore all of those, all of you that have tried to do a public works initiative, realize that those are all the reasons why you don't get to build the bridge. Not because you don't have the right materials, and not because you don't know how to do it. You have to actually acknowledge all the other things in the environment. So you guys were pretty good at identifying a lot of those questions you had to ask about building the bridge. We hardly ever do that in healthcare. As Karen said, if we have a problem in the emergency room, we're like there fixing throughput in the emergency room. We're not thinking about why the people in the emergency room, or what are the social issues and socioeconomic issues that drive them there. We're not kind of talking about the quality of care and in referring facilities and why people are bouncing back to the emergency room. So, we actually use our reductionist approach often to solve our problems in healthcare. And we want to teach our students and our faculty to just back up and say, this is actually a much bigger problem. And when we try to attack it, let's actually make sure we go into it acknowledging all the external forces that are going to create a positive solution. So why are we even worried about this at academic medicine? Yes. We don't have a curriculum to support it. Nobody gets any extra points on their boards for scoring well on this. There's no incentive for our students or our faculty to actually know this. But if you think about how healthcare is changing, For us not to have this body of knowledge would be really creating an unprepared leadership team for the future. As you see, we are actually moving towards systems of care where understanding how clinical systems interact is really important. But remember, this is within a payment system that's changing rapidly as well. I can tell you that if you want to stay in fee-for-service, you use spot solutions. But if you're moving into a Pioneer ACO or capitation, you actually have to think about the system that patient population is sitting in. I mean, we're finding a lot of our people that are running Pioneers are, paying for cab fare and buying air conditioners and doing things that they would never do in a fee-for-service system because they're actually accountable for the total cost of care. And there's some non-medical things they're doing that have a huge impact on the cost of care for that patient and the health of the patient population. And I think it's really the optics of caring for populations as you move away from fee-for-service, which is taking care of the patient in front of me, and eventually moving out to taking care of the community. In order to be successful, you have to consider not only the evidence, but human behavior, social systems, organizational systems in defining your solutions. And we are probably uniquely unprepared to do this. I mean, everybody's talking about population health. I love Ralph Muller at Penn. He's even talking about it, which is a surprise to many because Ralph is a very traditional, very, very successful CEO. But he said, we've got to get our arms around this population health thing. He says, we don't really know enough about this. And for leaders in academic medicine to start saying, we need to get on the bus here because people know more about this than we do, and we think this is key for being successful, is a major shift. So what are we teaching our physicians? And this is where we think we've really lost the thread. We're teaching them systems-based practice, and people are still struggling how to measure it, what does it mean? I think we never made the thread to systems thinking. We need to start having our faculty understand what systems thinking is, and systems-based practice is going to make more sense. Right now it feels like an add-on. It's another thing they have to do. Because I think we lost the thread to the origin of systems-based practice. And if you look back at the original systems-based practice literature, they actually talk about systems thinking. But somehow we didn't carry that forward. So we want this to become part of our kind of conversation with faculty. These are the competencies. I'm not going to go over them, but every single one of them actually demands you have a much broader view of what the problems are and what the solutions could be. Now, our favorite force of nature said, well, let's do something about this. So we convened here last year, and these were our goals. Understand the applications of systems-based thinking in our industry and the importance to population health. Identify the gaps in current activities in the curriculum. Create interprofessional collaboration that prepares people for care transition. And we had people from schools of nursing, we had engineering, we had business. It wasn't just providers in healthcare. And really identify what new skills new professionals need. We brought two people from MIT. This started in MIT. So we brought Eric Bergman and Retzef Levi from MIT, and they actually gave us a framework to have these conversations. The group actually broke into an exercise, and they demonstrated how narrow we sometimes get when we try to define a problem. But these three lenses are probably the foundation for the MIT approach to systems thinking. Organizations are machines, organizations are contests, and organizations are institutions. And you have to look at every single problem through those three lenses. And all of you in healthcare can understand, if you don't understand the political repercussions of rolling something out in an organization, you will not be successful. If you don't understand the cultural, the norms and standards, you will not be successful. But again, often we create these solutions we think are really perfect from a structural viewpoint, but they just don't work. There are some examples. Like a simple problem would be increase the number of people that receive flu vaccine. We've actually gotten pretty good at that. It was a pretty simple problem, and we hardwired it into a nursing process. So most of our institutions have about 98, 99% of patients that actually get their pneumococcal vaccines. More complex is implementing a safety checklist in the operating room. There's a huge gap between policy and practice. Probably 50% of the time, surgical checklists are not really implemented effectively. People dismiss it, there's a lot of talking, not everybody participates, and I can tell you the students and residents, if they saw something wrong happening, would not intervene. We know, we've polled them. 25% of the medical students would say something, and only 50% of the residents would say something if they saw a break in protocol on the surgical checklist or the central line protocol. So we really have not understood the politics within the environment when we try to deploy some of these safety processes. And even more complex is hand washing. We can't get people to wash their hands. And if you think about it, that is really their norms and standards and behaviors that are getting in the way of our ability to do that. So I just want to move forward to our next iteration. We published a paper that is actually going to be out on the iCollaborative, and we're going to do broad distribution to really create a case for change for our CEOs. We went one step further, and with the help of the CDC, we now have a grant that's connecting systems thinking and population health. So we're using the Duke curriculum, which you have a copy of on your chair. And we're working with Duke to actually take 2 cohorts. One cohort will go through the population health modules, and we've kind of honed it down so it's 1 year. The other group will actually have a systems thinking learning experience. Systems thinking doesn't require 250 credit hours. It requires probably, to begin with, a day to talk to people about how to think differently. People probably already have the tools and skills. They just have to think differently when they talk about solving some of these problems. So we're combining a learning experience with the Duke curriculum and actually going to measure systems thinking before and after and measure the uptake of the population health curriculum. The Duke curriculum is great. It is very adaptable, but it focuses on several things: using public health methods, engaging diverse community partners, critical thinking and assessment, using analytic and data-driven approaches, and this is where we can actually contribute to the rigor around that, and finally working together in interprofessional teams. So our next steps are really to demonstrate that there's a synergy. This is the first step of saying there is evidence to say that this type of thinking is a foundational competency, not just for residents and students, but faculty. And we need to invest in building that. We want to create a learning experience that's scalable and easily implemented, and getting clear on what success looks like in year 1, 3, and 5 years. These are the thoughts from the experts, and Chuck contributed a lot to these. The discipline has never been consolidated. There's a lot of stuff in engineering and business, but it's really never been consolidated in one place. They can say, this is really what systems thinking is and how it applies to healthcare. This is all about solving problems better. This is systems thinking to action. It's not just thinking for thinking's sake. I love this. Chuck says the PDSA cycle has never changed an organization, but systems thinking should change an organization. And Einstein says if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about solutions. He's probably right. We don't spend enough time really analyzing what are the drivers of the problem and how we can ensure success before we start implementing solutions. And we just want to create the capacity within our faculty to be able to do that successfully. So I'd like to actually invite the rest of the panel up, and I think they have other thoughts to share about the applications within our industry, and then we'll open it up for questions. Thanks.